Circadian rhythm and chronobiology. This is an in-depth review of our circadian rhythm. I know we've talked about it a lot before, but we're really going to kind of dive in a little bit deeper with this talk. So, the word circadian comes from, if we break it down, circa means about and diem means a day. So, circadian means about a day. It is genetically determined, so it would free run at a genetically determined frequency in the absence of synchronizing environmental time cues. And most free running human circadian rhythms have a frequency of about 24.2 hours. And this endogenous circadian period is referred to as tau. So it's endogenous, meaning it's created within. It's if we're allowed to free run, our bodies would run operate at about 24.2 hours. And so what that means is that if we didn't continuously resync our bodies up with the environmental time cues, as in our 24-hour time clock, we would slowly march our way around the clock, so to speak. And in the absence of light and dark cues to kind of resync us to if it's day or night, we would each night we would stay up a little bit later, a little bit later, a little bit later until after about a period of about 2 weeks, we would have fully circled the 24-hour time clock and came back to sleeping at night. So that's why we always have to resync ourselves up with our 24-hour time clock. So the number of these are some terms that you will have to learn, which ultimately just refers to the number of oscillations. So ultradian means it lasts slightly less than 24 hours, circadian approximately 24 hours, infradian meaning it lasts more than 24 hours, circaseptan every week, circannual an oscillation per year. And then just talking about some of the terminology when we talk about amplitude. So the amplitude is just height. So the from measuring from the peak or the bottom to the peak, the height to trough to the bottom. So we've heard me use the term nadir before, which means trough or lowest point, but mesor means mean or average, acrophase means peak or the highest point. And then the period length is the time interval between two consecutive events. So between two peaks. So if we have one, two, it'd be the time between the two peaks. So when we talk about the phase, it really is talking about the temporal. And I always had trouble because we start to use a lot more larger words when it comes to talking about this. And so whenever I see temporal, I just see the big T and I think time. Temporal, and the same thing if we're talking about different therapies. We had temporal techniques that were used with insomnia treatments. Always come back to thinking temporal timing. It has to do with the timing of things. So when we say what phase we're in, it has to do with the timing position in relation to our external sleep, light dark cycles going on, our external time clock. So if somebody were to phase advance, it means that their episode is shifted to an earlier time in the 24-hour cycle. Phase delay means the shift of an episode to a later time within the 24-hour cycle. And that'll come more into play when we talk about some of the different disorders. So, chronobiology is the study of the influence of the circadian rhythms on the various biological processes. And it's the study of the circadian rhythm at the molecular level. And there's been 7 genes that have been identified as the core clock components, which means that they're defined as genes whose protein products participate directly in the feedback loops of the circadian rhythm. And interestingly, what they found is our internal molecular clock is remarkably stable. And so they've done different things to see what can potentially alter our circadian rhythm. And it's fairly unaffected by temperature, by the transcription rates of other genes. It's a very stable internal system that we have to maintain our internal body clock. So, the circadian timing system is the set of neural structures within our central nervous system that help establish the temporal or the time organization of our different physiologic or bodily processes and our behavior into very precise 24-hour cycles. So, again, we're using a lot of words, but if you break it down, it really just it means that it's establishing we have these set of structures within our brain that really help to create this organization of the timing of our different bodily processes and our behavior, like sleeping and waking, into these very precise 24-hour cycles. It's very rhythmic. You could set your watch to it, you could somewhat say. So there's different three main components of the neural structures of the circadian rhythm. You have photoreceptors and the visual pathways that kind of take in and entrain the information from our outside world. And basically, what that means, the photoreceptors are our light receptors in our eyes, and then the pathway that those signals travel from our retina into our brain, into the hypothalamus, that help entrain and evaluate the information that's coming in. The pacemakers are what generate the circadian signal, so that would be your suprachiasmatic nucleus. That's your circadian rhythm pacemaker that establishes that very rhythmic running of our bodily processes. And then the third component of the neural structures of our circadian time system within our central nervous system are the output pathways that essentially keep everything in sync with each other. So then that way, all of our bodily processes are in the same mode or phase as the other bodily processes, if that makes sense. So you've got pathways that come in that are taking information in mainly via the eyes and the amount of light coming through. You have the part of the brain that interprets those signals that are coming in that help it to maintain their rhythmicity. And then from this pacemaker, you have output projections that go to other areas or effector systems that help kind of, okay, all right, guys, everybody, we're on night. Everybody be on night. All bodily systems should be on the night, pathway now. So those are the three main components of your circadian timing system within the brain. But the suprachiasmatic nucleus is your dominant circadian pacemaker. That's our circadian pacemaker, kind of the generator. Where it is located is at where the entraining pathways come in, meaning the the suprachiasmatic nucleus is mainly impacted via light, and so light travels through the retina along this path that ends at in the hypothalamus via the retinohypothalamic path. However, the SCN oscillates independently of the environment. It knows it just maintains its rhythmicity to increase firing during the daytime, reduce firing at nighttime, increase firing in the daytime, reduce firing at nighttime. I don't know if I said that right the last time. Um, and increase firing during REM sleep as compared to non-REM sleep, because really got to think of REM and non-REM as two very distinct and separate stages of being, not just stages of sleep. But remember, REM sleep is a very active stage of sleep. So it is what is promotes the SCN is what's responsible for help promoting that wakefulness during the day and helping consolidate sleep at night. The circadian rhythms in pretty much all mammals are generated by the circadian pacemaker in the SCN, and that's located in your anterior hypothalamus. So remember from Doc's class, an afferent connection arrives. So that means what pathways are coming to your SCN to help kind of input information to the SCN. And that would be from photic stimuli. So from light, that would be via the retinohypothalamic tract from the eyes, and then from non-photic stimuli. So the SCN receives input from several sources. Um, from the eyes, namely light, and then the retinal photoreceptors involved with the circadian process are most sensitive to the visible light of the shorter wavelengths, like the blue, blue-green. One of the ways you'll probably hear blue blocker sunglasses, they specifically block light of that shorter wavelength. But then you'll also get information from non-photic stimuli, like from the hypothalamus, from the basal forebrain, from the midbrain. And then these are the neurotransmitters that are important for maintaining that communication among these pathways. But glutamate is the main neurotransmitter that mediates the effects of the retinohypothalamic projection to the SCN. And so they found that things, either medications or certain conditions that block glutamate receptors, block the influence of light on our circadian rhythm. Really interesting avenue of research. So the SCN efferent projections, which remember an efferent projection or an efferent connection exits. So it's projections that are going from the SCN to other areas of the central nervous system to project its information would be to the hypothalamus, locus coeruleus, the ventrolateral preoptic nucleus, the basal forebrain, to our hippocretin neurons, to our pineal gland, to our thalamus. Some of these are new, and some of these should be areas of the brain should be reviewed from our A&P lecture. We know basal forebrain is important for regulating our body temperature. And remember, body temperature and circadian rhythm are very closely linked. Your pineal gland is important for the release of melatonin. Melatonin it stimulates the onset of sleep and prolongs its duration. So pineal gland and melatonin. Melatonin is only released when the lack of light is coming through. So those light signals either travel through the retina to the hypothalamus, to the SCN, and then the SCN projects it to the pineal gland. So it blocks the release of melatonin, or the lack of light would release melatonin. Thalamus, we know, is what's important and plays a major role in awareness and wakefulness, overall degree of arousal, because it's where all of our sensory input is first processed before being then diverted to the area on the cerebrum where it's actually felt. Remember, hippocretin, also known as orexin, is the fat kid on the seesaw neurotransmitter that helps stabilize sleep and wake. I know, again, this is just a quick review because it's gonna keep coming up. So hippocretin, orexin, our sleep and wake tends to be two very stable stages in humans mostly. But in dogs, if you notice, they fall asleep very quickly and they can wake up very quickly. And that's because they lack hippocretin. Same thing with narcoleptics. They don't have that stabilization to their sleep and their wake. So the SCN, when they've done studies on this area of the brain and have actually dissected it and took apart each and every neuron that makes up the SCN, all of them maintain on their own this rhythmic firing rate of about 24 hours. However, what happened when you took them all apart is they just started getting out of sync with each other. So instead of all firing and being in the same point within the cycle, they're still maintaining a 24-hour rhythmicity, but they start getting out of sync with each other. But together they keep themselves and everything in sync with each other to create that pacemaking function. Our internal circadian rhythm is created prenatally, like while you're still in the womb. Behaviorally, physiologically, the rhythms don't appear until after birth because there's a lot of other physiological needs that take over the 24-hour rhythmicity for an infant. But it's interesting that it's created, we're already kind of predestined to be morning people, evening people, however way it goes while you're in the womb. So when they've had patients or there's been instances where the SCN, there was either a lesion or a tumor or something that had impacted the SCN. And what happened for these patients is that they lost their circadian rhythm and they didn't lose the functions in and of themselves. Like they still could sleep, they still their body temperature still fluctuated, but it lost the rhythmicity that it would typically happen at. And so what happened was sleep started to become distributed randomly throughout the day and night. There was just no pattern to it or anything like that. And so what they found in these patients was the SCN keeps everything in sync with each other. It doesn't by losing the SCN, it doesn't change the function itself. Sleep. You still can sleep without the SCN. You just don't have that rhythmicity to it that you would have it with the SCN. And they've done transplants of the SCN. And what they found was that when they transplanted a fetal SCN into a host that had a lesion on their suprachiasmatic nucleus, the um, the rest activity site rhythm, the circadian rhythm that the recipient received started to their new circadian rhythm reflected that of their donor, not the host. So they were transplanted with an SCN and say they used to be an evening person, but the SCN that they received was a morning person. They took on the morning person traits instead of the SCN, adapting to the person and taking on what the person formerly was. I thought that was interesting. So some other non-SCN oscillators. So there are other components within the brain and the central nervous system that does help to um, maintain the rhythmicity of our circadian rhythm. And there are many tissues and organs, including the brain and areas outside the SCN, to help maintain that rhythmicity in the absence of input from the SCN. And what that indicates is that without the SCN input, the timing of everything started to really differ and start to go out of phase. So, what that indicates is that the SCN really coordinates the timing of the functions throughout the body and keeps everything organized and in sync with each other. So the cycle of our sleep and wake is controlled by two opposing factors. Remember, you have that homeostatic drive for sleep, and then there's also the circadian promotion of arousal. So this is relating back to our first lecture of the semester, the evaluating sleepiness and sleeplessness. So in the morning after awakening, there's basically no homeostatic drive for sleep because remember, the homeostatic drive for sleep is the longer we stay awake, the increase the drive for sleep, and the more we sleep, the reduced amount of our drive for sleep is that homeostatic drive. Um, but our suprachiasmatic nucleus helps to increase the output during the day to maintain wakefulness and decreases output at night to help sleep onset occur. So in the morning after awakening, there's basically no homeostatic drive for sleep and the output from the SCN is low. As the day progresses, our homeostatic drive increases and it's countered by an increasing SCN output. At the end of the day, the SCN output decreases and we have a homeostatic sleep drive, and that's what results in sleep. So, those two opposing factors, and that, if you need a review on the homeostatic sleep drive, go back to the Module 1 lecture, Evaluating Sleepiness, Sleeplessness. But entrainment is the process how we are able to utilize the external time cues around us to adjust our circadian rhythm, to adjust our endogenous and internal and natural circadian rhythm. We can set our phase, we can advance it or delay our phase of our sleep-wake cycle. We can set it forward, we can set it backward. And the number one way that we do that is with light. So if we were to receive light at dusk, that would cause a phase delay. So getting a lot of light at night would delay bedtime, make it harder to fall asleep, and we're able to stay awake for later. Receiving light at dawn when you first wake up would be light or would cause a phase advance. which means that it would really reinforce the early morning awakening, help you fall asleep a little bit earlier that night. Zeitgebars is a Zeitgeber is a German word for time giver. It is a word that you will have to learn, but our environmental time cues that are capable of helping to change our circadian rhythm. The most dominant synchronizer. Do you guys know what that is? Environmental light is our most dominant synchronizer or dominant and training stimulus for our circadian sleep-wake pacemaker. Changing the circadian phase of the sleep-wake cycle requires high-intensity light. But some other things that can help re-entrain your circadian rhythm would be the timing of your meals, the timing of your activities, social cues, what temperature is in the room going on, all of that. So, phase shifting is the displacement of our internal circadian rhythm in response to a Zykabar, in response to either receiving light, in response to, changing when we have our meals or when our social cues are. You guys are going to have to take on some different social cues now that you're on nights. But the SCN clock, it's if you think of it, it's an imperfect timepiece and it has to be reset repeatedly because we operate at tau, 24.2 hours versus what our time clock is at, which is 24 hours. So the light dark cycle sets the exact timing of the pacemaker. And this phase response curve shows that the pacemaker responds differently to light at different times of the day. So, there's certain times of the day, midday, where being exposed to light isn't really going to do much towards changing your circadian rhythm and helping you shift when you want to sleep and when you're going to stay awake. But by getting light in the evening time at dusk, early night, it's going to have a very profound difference and change in being able to delay going to bed. But there is this kind of trade-off right here where if you go and have too much light exposure too late in the night, it can have the opposite effect where it'll really reinforce advancing the sleep-wake schedule and keeping awake in these early morning hours. And so knowing where this light exposure is going to have the most profound effect and depending the potential outcome that we want. Do we want to advance our sleep phase so we're going to bed earlier, waking up earlier? Or do we want to delay our sleep phase so we are staying awake later and sleeping in later? Knowing that and where the light exposure is going to have its most profound effect can really help with the treatment of certain circadian rhythm disorders, but also just for your own knowledge if you need to, if you all of a sudden have a job or you're taking on a career where you're now having to maintain a schedule that isn't necessarily as endogenous to how your circadian rhythm runs. So there's two biological markers that we can use to estimate the timing of the circadian rhythm. One is the dim light melatonin onset, which is basically when melatonin levels start to rise, and you usually see that about 2 to 3 hours before your normal bedtime. And then also tracking body temperature. So when your minimum core body temperature is, that usually occurs about 2 to 4 hours prior to the end of your sleep period. And so here's a picture of it, of the sleepiness level and what you typically see with your body temperature. So we typically fall asleep when our body temperature is on the downswing and when our melatonin levels are on the rising phase. So notice that we have a little bit of a peak here in our body temperature. So one of the reasons why it's kind of hard to go to bed early, because it's hard when your body temperature is elevated, but then as it starts to drop, that's when it's easier to fall asleep. It reaches its CT min or minimum core body temperature about 2 to 4 hours before bedtime and then starts to go back up. So you've got to think that when you work nights, you're trying to go to bed on this upswing, which makes it really difficult to fall asleep. It can also significantly impair and impact the quality of your sleep. So here's a graphic that tracks the core body temperature throughout the 24-hour time cycle. So again, that's falling asleep, middle of the night, you hit CT min about 2 to 4 hours before you would typically wake up, and then it starts to go in its rising phase. So you wake up, hits its high point. You have a little bit of a dip. This would be your afternoon dip, where it's totally normal to want to take a nap or a little afternoon siesta, and then it goes back up. And then it starts on its down phase, and that's when you would typically fall asleep. So you can kind of track and correlate peak alertness levels and peak sleepiness levels with your body temperature. Our peak sleepiness levels is when our body temperature is at its absolute lowest. So this is one of the reasons why when you do your overnight shifts, that 3 to 5 a.m. hour is probably the absolute hardest to stay awake because of your circadian rhythm. And this is one of the reasons why, too, you probably feel the most awake and alert in the late morning hours and early evening because your body temperature is at its highest point in those times, typically. So melatonin, you guys remember where melatonin is released by, what part of the brain? Melatonin is synthesized and released by the pineal gland, and it's rhythmically increased secretion at night, reduced secretion during the daytime. It is regulated by our light signals that are being received by your suprachiasmatic nucleus. The production of melatonin does decrease with aging, and it has that mild hypnotic or sleep-inducing effect that helps promote sleep onset. Now, melatonin is less effective in phase shifting the circadian rhythm compared to light exposure, but appropriately timed administration of melatonin over the counter, it can phase shift the circadian sleep-wake rhythms. It can cause a phase delay if taken in the morning, but that's not really, great because it does have that sedating side effect. So you're taking something that is going to make you feel very sedated early in the morning, and that could make for a fairly rougher day. And it can cause a phase advance when given in the afternoon or early evening, meaning it can cause a person to help to fall asleep a little bit earlier when given in the afternoon, early evening, because it has that sedating kind of side effect to it. So in the pineal gland, the amino acid tryptophan is enzymatically converted into serotonin, which is then converted into melatonin. And your liver is what is metabolizing melatonin. And one of the reasons why I've always lumped serotonin in with a neurotransmitter associated with sleep, because low levels of serotonin cause low levels of melatonin. So, we're going to talk about circadian rhythm sleep disorders. And basically, what that is it's a mismatch between your sleep wake schedule of the environmental day and your internal circadian rhythm. So, it's an alignment between your desired or a misalignment between your desired sleep wake schedule and your propensity for sleep based on your endogenous circadian rhythm. And so by aligning your sleep wake schedule with your endogenous circadian rhythm, that's when you'll really see optimal sleep and wakefulness to occur. But when you try to sleep what's outside of what is natural and normal for your body to do, that's where you'll have the side effect of difficulty sleeping, insomnia, daytime sleepiness. It can cause a lot of distress and impairment, daytime, just it's stressful on the body. It's putting a stress and strain on the body, as you've come probably to realize with working nights. Some people can take to it easier, and some people, it is a real stress on the body. So, with circadian rhythm sleep disorders, there's primary circadian rhythm sleep disorders where there's just a shift of their internal pacemakers. And there's four main disorders that are considered a primary circadian rhythm disorder. And then there's secondary disorders, which means that you're just unable to adjust quickly to an environmental change, which could be jet lag. So it's secondary to traveling to a different time zone. It could be secondary to working shift work, secondary to some type of medical condition or a drug or substance abuse. So let's review some of the different circadian rhythm sleep disorders. So, delayed sleep phase syndrome is the inability to sleep during your desired hours. So, your typical internal phase is to go to bed and wake up a lot later than what is conventionally normal. And so when a patient with delayed sleep phase tries to go to bed earlier to closer to the socially accepted norms, they're not able to fall asleep. They have sleep onset insomnia, and they're going to be tired in the morning because they're not going to be able to fall asleep till when it's natural and normal for them to fall asleep, but that alarm clock is still going to go off whatever time it's going to go off at. It is the most common circadian sleep disorder that we see, with it being populating about point or with it impacting about zero point 0.2 of the population and about 5 to 10% of our chronic insomnia cases. So looking at circadian rhythm issues is one of the differential diagnoses that we have to do with insomnias to see, is it truly an insomnia, or is there just a mismatch between the patient's circadian rhythm and the cycle of sleep that they're trying to get. You'll typically start to see this start to happen uh, among adolescents, young adults. It tends to affect the genders equally. There's no gender predominance. But when the consequences of this disorder is the patient or the person can develop a sleep deprivation or a sleep debt if they keep trying to go to bed earlier and still have to wake up at whatever time that alarm clock is going off. And so, unfortunately, what you see oftentimes is these people tend to kind of be chronically late or absent for work or school, and that can really have a negative impact on their performance academically and in their job. And then the other problem with it too is, they in all likelihood will try to go to bed earlier to knowing that their alarm clock is going to be going off fairly early. And in those instances, and they're laying there awake, they can sometimes develop that conditioned psychophysiologic insomnia where they really start focusing on their sleep. They're starting to um, uh, relate their bed with not being able to fall asleep, and then the stressors and obsessing about it. So that's the other risk that you have to look at with these patients. So, kind of the pathophysiology of delayed sleep phase is it's just a phase delay of their circadian rhythm, and they have a hard time trying to advance their phase in order to correct this disturbance. Sometimes there are social and behavioral factors that contribute to it that could either bring it on or maintain it, whether it be, the person just wants to stay up late and continues to do so to play on their phone, to watch TV, more of like a behaviorally induced. But a significant number of individuals with delayed sleep phase report a positive family history. And but however, there is the genetic basis for this disorder is not completely understood, but it does tend to run in families. So, in order to diagnose this, we take a look at the patient's history. Sleep diaries are helpful to get a kind of an idea of what the patient's typical sleep schedule is, but actigraphy gives us that objective look at their sleep-wake schedule, and it's really helpful to monitor it for at least 7 days to really kind of establish that um, the habitual sleep period. So when you get examples of histograms, actigraphy like this, sometimes some software will actually like blue out what it estimates to be the person's sleep-wake schedule. And so you can see there is the rhythmicity that this person typically goes to bed right around 6 a.m., sleeps in until about, what is that, 12, 10, noon, 1, 2 o'clock, 3 o'clock in the afternoon. Typically, we don't need to do a sleep study on these patients because when allowed to sleep in the timing of what's natural and normal for them, their sleep is normal typically. It's not that their architecture or their, sleep is excessively fragmented. It's just the timing of when they sleep is off. So we don't typically do a sleep study for these patients, and the diagnosis mainly is made mainly on the history. Um, but the other thing that the physician has to look out for is Is it an underlying insomnia? Could it be the psychophysiological insomnia, that learned insomnia? Is there other things contributing to it, like psychiatric conditions, restless legs? Is it more of a behavioral or lifestyle thing that the patient is actively engaging in versus a truly physiological phase delay on their circadian rhythm? Or is it some other type of circadian rhythm disorder that might be causing their complaints? So we're going to talk about the different therapies. There's three main types. And again, we talk about a lot of different therapies and disorders in this class. So I strongly recommend putting together like flashcards and stuff. But what I like to break this down as chronotherapy has a lot to do with the timing, phototherapy with light, and then obviously pharmacotherapy, medications. So chronotherapy is, there's a couple different tactics that the person can employ. Either they can do a progressive phase delay or a progressive phase advancement of their major sleep period. Essentially, what you're trying to do is just get them eventually sleeping the sleep schedule that they want to be able to sleep, not what is natural to them. So progressive phase advance means that you're just slowly advancing the time that they go to bed and the time that they wake up. And it's done over several days, and they can pretty much maintain their normal schedule. It's not gonna, they don't have to take time off of work to do this. They just, okay, tonight you're going to bed about a half hour earlier, that alarm clock's going off a half hour earlier. And just really maintaining the being strict about the waking time is so important with this. The progressive phase delay approach has the person just progressively delaying their bedtime each night by 2 to 3 hours. So if you have somebody that has a really hard time going to bed early and that has really or has kind of developed that psychophysiological insomnia component to it, instead, what you're going to have them do is, okay, tonight you're going to stay awake 2 hours than what you would normally go to bed. And you essentially have them march their sleep period around the 24-hour time clock until they land it on the bedtime that they want. The instructions with this would be no napping because it's going to kind of really throw everything off that you're doing. Retime your physical activities, your meals, your light exposure to with whatever time you're on as you're marching your sleep period around the clock. It takes a few days to complete, but for some people that have trouble going to bed earlier, this might be a different approach that they could try taking. A different and third way or method to try to kind of adjust their sleep period time would be the schedule shift technique, which essentially is have them sleep normal, their usual sleep schedule for 6 nights. Seventh night, you don't go to bed at all. You have a night of complete sleep deprivation. And then that would make the person incredibly tired and sleep deprived. So then that eighth night or the next week, they go to bed 90 minutes in advance of when they normally would, and then they maintain that sleep schedule for the week, and they kind of keep going along that until they get their bedtime to where they want it to be. So essentially with this, the schedule shift technique, you're just creating a period of extreme sleep deprivation that would pretty much make it that the person could go to sleep a lot earlier than what they would normally be able to go to sleep after going through that period of sleep deprivation. With phototherapy, it's a light treatment. So in order to cause a phase advance, you want to have the person have a lot of early morning light exposure because you want to reinforce that early morning awakening. You want to be awake at this time. You want to instruct them to avoid bright light in the evening time. There isn't really a set guideline for how much light and how long. It's really individualized, but some common adjustments or therapies that you might see is somebody having 2 hours at 2500 sitting in front of a light box at 2500 lux, or if they're okay with doing brighter light boxes, they can reduce their time. It's all individualized based on the person's response to therapy and the potential side effects if they do experience any. The timing of light therapy is really important. The greatest benefit to cause a phase advance is really timing it as close as possible to CT min or the the absolute lowest point that the body temperature is at. The closer the exposure is to CT min, the more the robust the phase advance would be, um, based on this phase response curve. Having light exposure too late could actually have the opposite effect. It could cause a further phase delay. So one way, if you think of CT min, one way to kind of figure out when their minimum core body temperature happens is about 1 to 2 hours after their habitual mid-sleep time. So say they went to bed at midnight, typically woke up at 8 a.m. Um, CT mid sleep time would be 4 a.m., so CT min would be between 5 and 6 a.m. So if somebody that wanted to be able to go to bed a little bit earlier, if they had light exposure around 6 a.m., it would have a pretty drastic effect on helping them phase shift to wake up earlier and go to bed earlier. Because measuring core body temperature is difficult and it's impractical, it's not really worth kind of doing this 24-hour monitoring of a patient's temperature to just see where exactly their cycle is. Oftentimes, they'll clinicians, the physicians will just tell the patients, whatever time you wake up, have get light exposure right at that time. And then if it doesn't cause any phase advancement, wake up about a half hour earlier the next day and just have that light exposure until they note that they're able to kind of adjust better to waking up earlier and maybe start shifting their bedtime to a little bit earlier. So there is not a standard optimum or minimum length of therapy for light therapy. It really has to be individualized. And it is recommended that these patients do maintenance dosing. So even after they get their sleep schedule to where they want it to be, to kind of do like a every now and again kind of redose with the light therapy to help prevent relapse. Um, the bright light boxes, they come in different intensities for how bright they are, and they're only getting, light. They're not getting the ultraviolet rays that they might get if they were to go out into the sun. So contraindications to light therapy would be retinopathy, photosensitivity, mania. So that would be if you have bipolar disorder, migraines, because it can definitely exacerbate those conditions. And some side effects to look for would be headache, eye irritation. It can cause nausea, dryness of the skin and eyes, skin erythema, which is just redness of the skin caused by dilation and congestion of the capillaries, which is often a sign of just inflammation or infection. And if a person does have bipolar disorder, it can bring on that manic state a lot more quickly. So it's something to watch out for in patients for light therapy. The ASM recommendations regarding light therapy is that the physician should be well versed and well knowledgeable in light therapy and recommending how much for the patient to use, teaching them about limits, not overdoing it, and warning them of the adverse effects. Because when used within recommended guidelines, light therapy is generally safe. It's not a pill, it's just bright light. And you can even buy a light box for yourself. I did when I was working nights to help help with the adjustment of working nights. And it also is really good to do your makeup in because you see everything. It's a very harsh light. But yeah, you can buy them from just any store, Amazon, whatever. Light therapy does have utility. It is useful for delayed sleep phase, advanced sleep phase, other circadian rhythms for patients that still have a retinohypothalamic tract intact, even though they are technically blind. But there really isn't a set standard for how much light, how long they should be doing it. It's really more about the timing of when they're doing it. And the individual, and then beyond that, it should be individualized for, the brightness level and how long the patient is having that light exposure. So for jet lag, light therapy can be useful to help people, readjust their new time zone. So whether it be they need to stay awake later, stay awake earlier, you're going to time it based on, if you want to stay awake later, light exposure in the evening, reinforce an early morning awakening, light exposure in the morning. For shift workers, you can try to, help with the rotation from day to evening to night, or if you're switching from a night to day schedule, timing it before or after. There really isn't any recommended use for patients with dementia, though, because circadian rhythm abnormalities is a common issue in patients with dementia, but it really hasn't been studied in that population. So melatonin is effective at causing a phase advance for the sleep period by lowering your sleep latency when if taken in the evening. Its phase shifting effect is less potent than bright light, but it does help with patients because when taken in that supraphysiological dose, meaning when you take it in pill form, you're kind of getting this like huge kind of dose than what you would normally your body would normally produce at that given time, it does have a sedating effect. So it can help patients that might relapse back to their old ways if for delayed sleep phase to kind of help bring them back and get them sleeping earlier to help get them back on the schedule that they want to be on. The FDA does not approve melatonin for circadian sleep disorders because it's over the counter. It's not FDA approved. So it can, things to watch out for is it can worsen asthma. It should be avoided in pregnant or breastfeeding women because it hasn't been studied. And because it is a sedative, you do have to, be careful about engaging in any type of activities after ingesting it. It's one of those things, take at your own risk, but it's come so commonplace. And I know even, for kids, some parents give it to their kids to help them sleep. So it's not within our scope to recommend medications, but it's certainly something that you could recommend the patient ask their physician about. Other medications or pharmacological treatments, vitamin B12 is one over the counter that's vitamin that's thought to help the suprachiasmatic nucleus entrain the effects of light. So you can take that with light therapy and it's supposed to, be a little bit better. Obviously, you could take sedative hypnotic agents to kind of just sedate yourself. You want to go to bed early, you take a sleeping pill early and you'll fall asleep. But there really hasn't been a ton of research on those two items. I mean, obviously, sedatives help you fall asleep, but remember, most are not approved for long-term use. So you've really got to teach the patient these other tactics, light therapy, chronotherapy, to help shift their internal circadian rhythm outside of, just sedating themselves with a medication. Other behavioral interventions that need to be maintained is, these patients that are high risk of relapse. So once their desired sleep-wake schedule is established, now their efforts need to shift to maintaining their new sleep pattern because the risk of relapse is really high. So they need to make sure that they are maintaining their regular sleep schedule throughout the week and are very well averse to the hygiene practices, sleep hygiene, and they're paying attention to them. And if there is a history of relapses, they can do ongoing maintenance therapy, either with bright light or melatonin, whatever method worked best for them, they can do. So advanced sleep phase syndrome is shifting the major sleep period time to a time that's earlier than what is normal and conventional. So with these patients, they really have difficulty staying awake any later than what they would normally go to sleep. And oftentimes they're waking up pretty early in the morning. And what makes it a syndrome or a disorder is they're waking up earlier than what they want. And these patients or people generally report being most alert in the morning. And so sometimes you can see why it'd be problematic if if they can't even stay awake beyond 6, 7 o'clock at night and are waking up between 2, 3 o'clock in the morning. That can be problematic if are, wanting to maintain a normalcy with their family or things like that type of schedule. So, the main complaints of people that have advanced sleep phase syndrome is they feel really tired in the late afternoon and early evening, and they can't stay asleep until however late that they want to stay asleep too. So it could cause some sleep deprivation. If they try to stay awake later, if they can stay awake a little bit later, oftentimes they're still waking up at their habitual awakening time. So that can lead to a bit of sleep deprivation. Again, as with all of these, it can develop into an insomnia, that conditioned or psychophysiological insomnia, depending on the behaviors and thought processes that the person is engaging in response to their sleep issues. And then there's a lot of things that contribute to the phase advances because when they are waking up early, you naturally have that early morning light exposure. And if they're going to bed earlier, the earlier bedtimes limit that evening light exposure. And both of these contribute to that phase advance. It affects about 1% of middle-aged adults, less common than delayed sleep phase, and typically see its onset later on in life, and the prevalence of it does increase with age. So delayed sleep phase tends to be the adolescents, advanced tends to be the elderly. There is no gender predominance, but seeing this outside of middle-aged and elderly is rare. So seeing it in like your adolescents, you really wouldn't see it. But what the thought behind what's happening physiologically with these patients is there's just an earlier phase in their timing of when their melatonin onset occurs, when their core minimum body temperature is reached. Exactly why, it's not known, but maybe just they have a deficiency in their ability to phase delay, an overly dominant phase advance. Maybe they just naturally have a faster circadian rhythm or a very short internal period length of their circadian rhythm. So, where most of us run at 24.2 hours, these patients, they just might run slightly less than 24 hours. So, that could be why they have such a hard time staying awake and, staying awake as late as they might want. The evaluation for these is the same as delayed. Have the patient keep sleep logs or do the actigraphy on them, still do a full evaluation on them, rule out other major mood disorders, especially depression, because depression can also present with the early morning awakenings. Therapy is, the same kind of tactics as delayed sleep phase, but instead you're almost reversing them. So instead you're going to have bright light therapy in the evening time, right before the body temperature drops to its lowest. And you really want to try to minimize the light exposure in the morning hours. And what they can do is with chronotherapy techniques to gradually try shifting their bedtime slightly later. So not staying awake too late, that if they still wake up pretty early the next morning, it's going to cause that sleep deprivation, but staying awake a little bit later, and hopefully the waking time kind of follows suit with that. Irregular sleep-wake pattern. Um, what this one is essentially there's no circadian sleep-wake cycle. There's no rhythmicity to the person's um, to their sleep pattern. It's very disorganized and it's pretty much spread out across the 24-hour time clock. And usually too, they don't even have necessarily one consolidated sleep period. It's more like they have three more naps that kind of together, if we combined how much time they spend in each nap, it would combined equal like a normal amount of night sleep, but it's just not a consolidated period and it's just very sporadically spread out across our 24-hour day. And there's no consistency to it, so it varies from day to day. It's unpredictable, it's inconsistent. So the thought process behind this is it could be that there might be something wrong with the person's circadian clock with their suprachiasmatic nucleus. It could be seen in people that just aren't able to synchronize the environmental factors, like they aren't able to synchronize, take in the cues from their light dark. It could be people that are normally normal, cognitively intact, but they just ignore it. So, they just don't even care. They just indiscriminately nap throughout the day, spend a lot of time in bed. I've seen this in patients that are on the sicker side where they're just kind of, they don't really ever get out of their bed or out of their recliner throughout the day. So they kind of just doze off and on and watch their TV throughout the day and, sleep when they want and stay awake when they want, watch TV when they want. They just kind of, that's their life. It's rare in the general population. You mainly see it in people with brain dysfunction, dementia, head injury. It can occur at any age. No familial pattern. There's no gender predominance with the irregular sleep-wake pattern. To really diagnose this, you want to take a comprehensive sleep history, sleep logs. But again, sometimes they don't even realize when they nod off and wake up. So actigraphy might be beneficial, but if a lot of times these people, especially if they're just in bed, it's not, I don't know how much it's going to see, but you really got to look at, is it sleep hygiene or is there other, is it truly, an underlying circadian rhythm issue? Because sometimes what they see with these patients is their circadian rhythm is just kind of flattened. So there really isn't the fluctuations that you would typically see in the body temperature and the hormones. It's just a flattened profile versus those typical ebbs and flows that we see in most other normal persons. So therapy for this really needs to be individualized. Like you could try light therapy, really working on their sleep hygiene to try to get them to have a more consolidated sleep period. So you can try melatonin in the evening, hypnotic agents. But again, chronic use really should be avoided. The big thing this is behavioral modification. So trying to get the person working with them to maintain a regular sleep-wake schedule, get out of bed if they're not sleeping, so avoid the indiscriminate napping, and really kind of more structure the day to kind of help be those non-photic entrainment devices like the timing of meals and social activities to get the person on a better schedule. Free running or non-entrained type, essentially what that means is the person, instead of following all of these synchronization cues that we receive from light and dark, social cues, all of that, the person just follows what is internal. They follow their endogenous circadian rhythm. It free runs. They non-entrain, they don't entrain in the external time cues. So basically, their sleep-wake patterns are relying solely on their intrinsic endogenous biological rhythms, on their circadian rhythm. And because our circadian rhythm runs on a period of slightly longer than 24 hours, you will see that their sleep period will kind of march around the 24-hour time clock. So typically their sleep onset and wake time is delayed by about an hour each day, and their sleep period kind of marches all the way around. And they basically, it's what we would all do if we were allowed to sleep ad libitum, which means at liberty. So because of this, if somebody were to have this free running circadian rhythm, um, being able to maintain the schedule necessary for school or employment is just not really there. So you rarely see it in the general population. You mostly see it in totally blind individuals who don't have that retinal hypothalamic tract, so they're not able to take in any photic or light signals. And then it's the blind, and it's also people that have like a psychiatric or behavioral disorder, um, because that just don't really have much of a social cues either. Um, because so the thing with the blind people, light stimuli isn't necessarily absent in all blind people. Some of them are considered blind, but they still might be able to see light. And then for those people, this is less of an issue. But it's for the blind people that don't have the ability to see light at all. Um, some blind people are able to partially entrain to their environment using non-photic factors like social schedules, And some blind people are able to re-entrain based on photic cues if they have an intact retinohypothalamic pathway. But blind persons with an intact retinohypothalamic tract um, are able to synchronize to external photic, the external kind of light cues, and are less likely to kind of develop this. So you see it sometimes in patients that are severely schizoid or have the avoidant personality disorders, dementia, things that can impact the SCN, so hypothalamic tumors, brain injuries. There isn't a gender difference or familial pattern. It can happen at any age, and if left untreated, it can be chronic, unrelenting. It's just they kind of just go to bed when whatever feels natural and normal for them. So kind of the thought behind the physiology behind why this can occur in some people is either that the person isn't able to entrain the the environmental kind of influencers that can help entrain our sleep-wake cycle, or if they have a markedly longer internal circadian rhythm. So most of us operate at about 24.2 hours, but in some people, they might have a slightly longer circadian rhythm. So for them, it's even harder to resync to a 24-hour time clock. Other components of it, if they have a kind of dampened melatonin profile, where it might be deficient or delayed in its release, causing them to continue to go to bed later each and every night. Um, Other components of it, it could be if in people that can see, maybe they just disregard what's going on around them. They disregard the light dark cycles or their social cues. They're just not that sensitive. Their body isn't sensitive to light, that type of thing. How we would evaluate this is sleep logs, actigraphy, and just watching their sleep pattern. And you would watch it march around the 24-hour time clock. Sleep efficiency is usually normal, and if the physicians were to do body temperature monitoring and measurements of their melatonin onset, usually you see it just progressively keeps delaying each on subsequent days. But free running or non-entrained, it really should be considered in any blind individuals who come to the sleep lab with complaints of periodic or recurring episodes of insomnia and daytime sleepiness. Because sometimes, um, it gets worse as when their sleep period should be at the other phase and they're trying to sleep normal. The other thing you got to look at when you have this, the differential diagnosis would be delayed sleep phase syndrome or other causes of an altered circadian rhythm, whether it be medical, neurological, psychiatric, behavioral disorders, medication use or abuse, anything like that. So treatment for this would be melatonin at bedtime to help try to entrain the circadian rhythm. If the person is able to take in the light signals, you could try light therapy. Um, Other non-photic stimuli would be really maintaining a regular schedule of bedtime, wake time, activities, meals. Medications like hypnotics to help them fall asleep, stimulants to help them stay awake are less effective because it's not going to ultimately change their circadian rhythm. But using these entrainment techniques like non-photic entrainment and light therapy is what's going to have the most drastic effect. Time zone changes can cause what's known as jet lag syndrome. So that just means that your internal circadian rhythm is not synced up to wherever the timing of the time zone that you just traveled to. Um, we're all different in how our susceptibility to jet lag, but generally, the more time zones that you cross, the worse in severity that jet lag can be, um, and also traveling in which direction that you're traveling. But the main complaints of jet lag are difficulty sleeping, disturbed sleep, waking up a lot, being really tired. Um, some people complain of stomach upset, feeling just overall not feeling good, uh, decrease in their mood, and typically the symptoms remit spontaneously within a few days. And kind of the rule of thumb is approximately a day for every time zone change. But um, sleep-wake schedules should be immediately changed to accommodate a new destination on the time and the day of the arrival. And how you can do that is with appropriately timed exposure to light. That can kind of help that synchronization between your body to whatever time zone you've just traveled to. And short-acting hypnotics taken at your new bedtime can help with complaints of insomnia. But eastward travel is more difficult than westward, because, say, traveling eastward, you have to cause a phase delay. It's causing a phase delay in the new time zone. So you have to kind of make yourself fall asleep earlier and wake up earlier, which is really difficult. Um, Traveling westward is a little bit easier on the body, because you just have to stay awake a little bit later, and you know you can sleep in a little bit later, a little bit easier on what's kind of follows our natural order of things. But everybody's different susceptibilities to how severe jet lag might impact them. Shift work disorder, which is a disparity in when you're working and when you need to sleep. So you have to kind of ignore the conventional time cues of sunlight and social activities, because you have to work when you would normally be sleeping and you're sleeping when you would normally be awake. Not every person that works shift work develops this. Some people adapt fairly readily to working and sleeping in very non-conventional hours, but other people can be very sensitive to this. So the common complaints seen in people that work shift work is insomnia, difficulty sleeping, having a hard time falling asleep, being very tired when you are awake, just kind of this chronic fatigue and chronic feeling of being unwell. Stomach upsets, greater risk for alcohol, substance abuse dependency. I know I talked a little bit about shift work in Fundamentals 1, so in my sleep hygiene talk. So if you want to refer back to that, you can. That's what I recommend. You go back to that. But the main therapy for this is to try to maintain a regular and comparable sleep-wake schedule, whether you're working and whether you're not. Easier said than done, because when you're working overnights, you're sleeping solely during the day, and that makes it really hard to make it to appointments, make it to certain offices that are only open during normal business hours, grocery shopping, all of that, maintain a normal social schedule. So one of the things that was recommended by the doc that we worked for said just try to keep semi-regular. Keep a block of time where whether you're working or whether you're not, your body knows it should be asleep. What I mean by that, let me give you an example. So when I worked overnights, I worked from 6 p.m. to 7 a.m. and I would sleep typically, I would try to sleep 8 a.m. to 4 p.m. On my days off, I would sleep typically between like 3, 4 a.m. to noon. And so, whether I was working or whether I wasn't, the 8 a.m. to noon, regardless of whether I was working or not, my body knew that was a chunk of time that I would be sleeping. And so I gave my body just that little bit of regularity of sleep, because there was no way I was going to stay on the full night schedule on my off days. Whenever possible, try to minimize the things that you know can work against you when you're trying to sleep, light, noise. Some recommendations are to limit light exposure on your trip home from work, especially if you're really sensitive to light. It can really make it harder for you to fall asleep when you get home. On the flippy flop of that, though, if you're having a hard time staying awake on the drive home, you need that light exposure. So you'll hear two schools of thought. Some docs will recommend limiting light exposure. Other docs are more worried about the safety and you getting home and want that light exposure. So you kind of gotta figure it out, what works best for you and how you're feeling in the morning. There you can take hypnotics to fall asleep, stimulants to stay awake. I've seen plenty of night shifters kind of get on that bender, to each their own. And then the other component of it is to have bright light exposure in the workplace. So I used to sometimes bring my light box with me for the overnight. And when I started feeling tired, kind of sat in front of it, and it really kind of, you're not falling asleep in front of that thing. And then you can't really do it in our line of work, but there is the recommendation for scheduled napping on the overshift on an overnight or shift work. Other fields and other careers, it is an option. It's not an option for us because we need to monitor our patients throughout the entire night. But don't be confused if you see that as an option for a test question, as what can you do to help yourself stay awake throughout the night? This is one of them that you can that is a recommendation out there. Not for us, but it is a general recommendation for shift workers. I found that anytime I did ever take a nap in the during my overnight shift, and I wouldn't do it when I had a patient, but say for instance, like I was scoring, some nights I would score instead of taking patients if we were low on patients, and I would kind of get through with my scoring that I wanted to get that I needed to get through with, and then I would put my head instead of taking breaks between scoring, I would just, put my head down on the desk for a half hour. And I actually found that I would feel worse when I woke up because it it was natural and normal for me, my body to be asleep at that time. And instead of like going in for a nap, it wanted to sleep the whole night. So I found napping actually like made me feel a lot worse on overnights. But it is an option. You think of a pilot, they're allowed to on the long overnight flights. Usually there's a couple of them, and one will take a nap while the other one takes over. It is one of the recommendations. That's all I got for this one. So comment, look back if you still want to look up more and what we've already covered on this. Sleep hygiene lecture from Fundamentals 1 has a lot of that. The stuff on shift work disorder and the A&P lecture too on all kind of the some of those A&P basics that we reviewed in the beginning of this.